Thanks. Comments from the panel?
It's a great presentation, Chadi. I would add and Manos is here and he can speak to it, is that, much of the focus is on Twitter, which I think is where most of us are, right? But as you know better than all of us, there's a number of platforms, and particularly YouTube, so when you think about YouTube, it's a very educational platform that you can put videos in. I think particularly of Manos' channel, like here in this meeting, it's a great meeting, there's 1,000 people. I think he has a video on DK Crush that has like 100,000 views. We would need a number of CVIs to teach how to do DK Crush, and he does it. So actually, at Mayo now, it's been, I think, a few years, he was actually pushed by the ER. They've started because of all the people that are doing podcasts, videocasts, these sort of efforts. They try to quantify that effort, and if you are able to show that you're teaching, that there's a metric and that there's an opportunity for feedback, for people to comment on it, it can be quantified for your promotion from assistant to associate and so on.
So, I mean, the truth is many of these things, for example, Manos' videos, your posts, are far more impactful to practice than some paper that only a few people have cited and read.
Yep. Yeah, I think what we need is just a more precise message as to what to quantify, what's real and what's noise, and that's, I think, where they need it.
It's true. So you have to be very, very careful, and you have to keep it very professional, because you can self-destroy. I mean, don't take risks. Don't make any statements that can be misconstrued. There was a recent case of somebody from Oregon that posted a statement that I don't know how to take, but it could be interpreted as hate speech. So there was significant response from the rest of the country about that tweet.
But I think just as we all consume data and opinions in life, and talk to people and listen to their opinions, this is just another venue for that. It isn't the truth.
Yes, but it's there forever.
Yeah.
So whatever you say, you can say, well, I never said that.
But what I mean is when people are critical of something or are embracing of something, it is their opinion.
Yeah.
And we should also remember that this is a selected group of people who are participating in this, and nothing, any of us have been around the block know that nobody's opinion is really the truth.
Yeah. Any comments about the humble brag?
Arnold?
Yeah, just a quick, along those lines, we all see examples of tweets that people might have regretted. Is there any specified time that you guys think about the tweet before you send it? Do you wait for 5 minutes? I mean, in email, you wait overnight if you have a questionable email. But if you do that in Twitter, it's too late. So how do you balance the rush to get it back in, a great response with the caution that you're advising?
There's no rush. Nobody's going to die if you don't put a tweet up there.
But there's a psychological urge sometimes to
Yeah.
tweet, and then you see the life of people tweet it. And what about the humble brag? That's something that really bothers me. Humble brags. I mean, humble to have received this award, humble to have published this other stuff. I mean, that noise really annoys me. So I know no one talks about that, but I think you should. I mean, we should say something about that.
I'm going to actually cut it off because we're running out of time. We're going to invite Chadi. Your next talk is actually not innovations in social media, but Manos is going to invite you what not to do in social media, maybe. Okay. All right. Dr. Sandoval is going to talk with us about innovation in cath lab safety. Welcome, Peter.
Thank you. All right. Thank you to the organizers for inviting me, and all of you for being here in the last talk and the last session. So I won't take much of your time, but there was actually at the complications course, there was a phenomenal talk going over all the basics of radiation and its strategies to reduce radiation. So I'll provide a basic overview, but really I'll try to talk more a little bit some of the innovative issues. I think the reality is that I'll try to talk about the safety issues that impact operators for the most part, rather than patients. And the reality is that there's a number of occupational hazards in our field. There's musculoskeletal issues, as many of us are aware. There's radiation issues, and there's increasing research in the effect of burnout, sleep deprivation, and all the downstream negative health consequences that are intrinsic to the field. Manos and Angelovo recently published this paper on the impact of sleep deprivation, with over 70% of respondents were interventional cardiologists, and around 9% report reported an adverse event related potentially to the impact of sleep deprivation. So just issues that we have to keep in mind. For musculoskeletal issues, this is exceedingly frequent. Actually, there's a very nice paper from Mayo by Mandip Singh that evaluated this. It's around 60% report, particularly in nurses and technicians, followed by physicians, and that the lowest incidence would be trainees. For the purpose of time, I'll focus on radiation issues. So for radiations, I think, it's following the message that Mauricio and others had. Even though there's some innovative approaches, there's some variation in the use of basic strategies to reduce radiation. And this must be continuously, I think, enforced and be just part of what we do on an everyday basis. Those include reduced fluoroscopy use, collimation, low frame rate, fluorostore rather than cine, a high table height, detector close to the patient, shallow imaging angles, and keep extremities out of the beam. So again, even though there's some innovative approaches that I will discuss, I think this to be part of every procedure and what we teach. This is some of the innovative approaches that have developed over the past recent years that range from potential, innovative approaches on AI to, of course, caps, sealing suspected shielding, robotics, and so on. So let's go over some of them. There's been the development of differential image quality technology. And essentially what this does is essentially that it creates a region of interest that you can track either with eye tracker or tablet. So let's say you're just focused on let's say the circumflex and you don't want to look at the LAD or other areas a little bit more, you can just pinpoint that with your eye tracker or with the tablet, and there's going to be an increased dose to that area and reduce the radiation dose outside that area, region of interest that you selected. So just be aware that the Controlad, I know they recently had FDA clearance. I'm uncertain about the FluoroShields, but there's emerging technologies that will focus the region of interest to the particular area that you're working on and associated dose reduction on that. As I said, there's a number of issues with orthopedic injuries and musculoskeletal issues. The rate of pain, it's exceedingly high. And the lead, for example, my lead, the other day I recently weighed it just because of this, it's around 14 pounds. So if you're wearing 14 pounds on your back for many hours for a career, that has an impact. So just be aware that there's ceiling suspended shields. One of those technologies is zero gravity. So one of the ways that can be used to reduce the impact on your back. And actually this zero gravity lead, it's actually has more lead than the usual LEDs that we use in our back, so it has more protection without the weight on you. One of the other technologies is essentially creating more barriers to reduce the scatters. This is from Robert Wilson. This is the AGNES system, and essentially you will use your usual shield, but in addition to that, as you can see, there's other adjustables, leg and femoral shields that can be used, as well as other internal shields to essentially try to really, essentially, as it's called, create an AGNES and reduce the scatter as much as possible. And one of the newer technologies that has been around, I think, for some time, but not many people use it, would be essentially real-time radiation dosimetry. This is for both patients and as well for operators, where essentially if you have these technologies, it's going to tell you on the screen every person and it's inside the cath lab, what are the doses, and essentially will alarm you if you are at a higher rate, so you can step backwards or essentially see whether you can do anything to modify the dose that you're receiving on a real time. Something that there has been increasing use has been, of course, robotic PCI, and I think this addresses both reduction in radiation and orthopedic injuries, and essentially, you essentially will step back and do the procedure remotely. As you know, there's been some recent cases that have been done for cases in both humans and animals recently, and so this is another field that will continue to see some work. I did want to touch base a little bit on artificial intelligence. So there was a session actually 3 days ago on that, and even though there's no robust research specifically addressing that AI reduces radiation, the whole purpose is that there will be a lot of information, particularly from image processing and computer vision, that is going to allow to acquire information, interpret images, and create risk stratification or aids in diagnosis, for example, such as angio-based FFR. So if we develop these tools with machine learning and artificial intelligence, essentially there will be a lesser need to be at the table using wires to get that information. So just think about that. This is a very nice paper just getting JAC Interventions this week by Sartor and Jay Geary, and it really talks about what is the cath lab of the near future potentially, since many of these technologies exist, and really how to integrate this. And this is really an integration of both robotics and artificial intelligence, and really making a lot of these decisions in real time, potentially in a way that it will be reduce both the incidence of musculoskeletal and radiation issues. But the issue is it all just about innovation? You know, there is a lot of risk. So this is actually a nice slide from Rajiv Bugulati, courtesy of him. And it says, you know, this is a paper from Goldstein. It says, we strap on our pads and helmets and enter the field of play. We play today, but we pay tomorrow. The reality is that, you know, and this is, I think Andrew's here, very nice viewpoint in circulation. And from the hospital perspective, there's really not much incentive to provide the best radiation systems. And as it goes in this very nice viewpoint, that really the approach has been hire them young and bright, work us hard, pay us well, and whenever we have health-related issues, redeploy us to other roles and replace us with another young and bright. And we do this, we're here at these meetings, we get exposed to radiation and these occupational hazards because there's some degree of denial about the long-term risk. And we recognize and accept the risk, and we really enjoy what we do. But there's many opportunities to advocate for better systems. To that point, this is a very nice paper by Manos and his group, and they compared a number of radiation systems. And as you can see, I mean, you can tell me which system you're using, but there's huge variation in the degrees of air karma that you're exposed to depending on what your system you have. And that just raises to the point, is there an opportunity for increased standardization and more advocacy to make sure that we have the systems that have the less air karma exposed to patients and operators? To that point, I think there's also an opportunity to talk about how to increase diversity in our field. So there's been a number of papers in both JACC Interventions and JACC about how it's been pretty flat now over years, the number of women in interventional cardiology. This is a recent graph that I made from ACGME, and as you can see, it's been pretty steady over 8 to 9%. And if you look at the data from interventional cardiologists and sex differences in pursuing the specialty, even though there's statements from SCI that there's no significant harm from a pregnancy perspective, it's an ongoing issue that regardless of consensus statements, this concern remains a major deterrent to pursuing the field of interventional cardiology. So we want to make our field more diverse and attract more women, we need to get better radiation systems. So in conclusions, I think we need to continue to enforce basic strategies to reduce the incidence of work-related occupational hazards that they need to be routinely used. I think there is a very nice, I would point you to that review by Jay Geary, there's an emergent role of the integrations of robotics and artificial intelligence to improve how we do things and hopefully reduce the incidence of occupational hazards. And I would really emphasize the third point. I think that to maintain the health of the workforce and promote diversity, there's an urgent need for increasing advocacy, maybe at the societal level, to ensure that the workforce has the best radiation systems and that we don't go around the room and somebody tells me that they have zero gravity, robotic, imaging, a number of tools. Another person has an older system with none of the contemporary techniques. Thanks.